Good afternoon. Thank you all for coming. Welcome to the second of three webinars on the Behavioral Health Centers of Excellence, the COEs. My name is Michael Uliberry. I'm the section chief in the BH Connect Section 2, which is in the Medi-Cal Special Projects branch in the Medi-Cal Behavioral Health Policy Division at the Department of Healthcare Services. During today's session, the DHCS, together with Health Management Associates, HMA, and representatives from the individual COEs will be providing a high-level overview of the adult behavioral health COEs and their training and technical assistance approach to each evidence-based practice, EBP. In addition to DHCS and HMA, we want to acknowledge the MANAT team as a key collaborator for DHCS as policy consultants that support the intersection between BH Connect and the Behavioral Health Services Act, BHSA. If you have any questions during today's session, please feel free to leave your question in the Q&A feature at the bottom of your screen. With that, I'm going to pass this over to Patrick Metters with Health Management Associates to begin the presentation. Thank you again for your attendance.
Thank you, Michael. So my name is Patrick Metters. I'm an associate principal with Health Management Associates, HMA. We're an independent national research firm and consulting firm with expertise in multiple disciplines, including behavioral health. DHCS has partnered with HMA as the Behavioral Health Center of Excellence administrative entity. Before we really get started, we do have a few housekeeping items just to make sure that everybody was aware. We are recording today's presentation, and it will be available on the Behavioral Health Centers of Excellence Resource Hub following this call. We will also make sure that the recording and slides are sent via email. Given the amount of information that we're going to be sharing on today's call, we're not going to be able to answer the questions live. However, we do want to make sure that we encourage you to insert your question into the Q&A function at the bottom of your screen. If you can't see a Q&A, click on More and you should be able to find the Q&A function at that spot. Drop your question there. HMA is going to be tracking and logging all those questions and making sure that written answers and additional information is provided to all that attend. We will also be discussing these at the upcoming Q&A session, which is coming up next week. As a reminder, when you registered for this webinar, you also received an invite to a Q&A session that will occur next Wednesday on the 13th at 1 o'clock. Next slide. For today's presentation, we're going to be covering a number of topics. The primary topic is going to be the overview of the Adult Centers of Excellence for assertive community treatment, as well as coordinated specialty care for first episode psychosis, individual placement and supported employment, as well as clubhouse services. We will also touch base a little bit on what we covered on webinar 1 related to the engagement process overview and next steps. I think we do need to make sure we also reiterate that during today's session, we're not going to be covering anything related to policy guidance on fidelity requirements, billing related questions, incentive structure or data elements and reporting requirements. Additional guidance is forthcoming in policy guidance and BINs, and we won't be able to answer those questions at this time. I think it's also important to reiterate that the Center of Excellence is not intended to have a role in compliance. Their role is to really support the counties and their contracted providers and practitioners in delivering high quality care. DHCS's role is really to set and enforce the compliance to that policy. So moving into the next slide, and then the subsequent there, we're going to go through an introduction and an overview of the Centers of Excellence and a lot of the initiatives related to BHSA and BH Connect. As you're well aware, implementing evidence-based practices is really central to California's goal for expanding access to strengthening that continuum of community-based behavioral health services, especially for those individuals living with significant behavioral health needs. EBPs are key components of both initiatives for both BHSA as well as BH Connect. And DHCS, in an effort to support implementation of these evidence-based practices, has established centers of excellence to really support behavioral health practitioners as well as counties in implementing these EBPs to fidelity under BHSA as well as BH Connect. On the left side, you'll see all of the different EBPs that are supported by centers of excellence as a part of this initiative. For the purposes of this particular webinar, we're going to focus on the ones related to adult population, so assertive and community treatment, clubhouse services, coordinated specialty care for first episode psychosis, and individual placement and support, IPS. Next slide. So for the selected centers of excellence, there's 8 evidence-based practices under this initiative. We have 4 centers of excellence that will present today. We will have UCLA Public Mental Health Partnership, who will cover assertive community treatment. We'll have EpiCal, who will cover coordinated specialty care for first episode psychosis. And we have IPS Employment Center covering individual placement support. And Clubhouse International will present on Clubhouse services. For more information, and I believe it was dropped in the chat, please be sure to visit our COE resource hub, and we'll talk a little bit more about that, but that is going to be where you can get the latest and updated information related to this initiative. Next slide. Given the complexity of both BHSA and BH Connect, it's important that both of these initiatives and implementing EBPs is closely coordinated. So you'll notice that there's some shared features related to EBPs for both BHSA as well as BH Connect. And you'll see from an implementation requirements all the way to access to training and technical assistance and fidelity monitoring, as well as some shared workforce requirements. A few other things just to make sure we point out, counties as of 2025 can start to opt in to cover evidence-based practices under Medi-Cal, so under BH Connect. So ACT, in fact, IPS, and CSC are covered underneath BH Connect, and you can opt in by 2025. However, we do need to mention that the core requirements related to all 3 of those EBPs are identical regardless of whether or not a county opts into BH Connect or maintains the requirements for BHSA. I think it's also important to make sure we highlight under BHSA, counties must offer ACT, in fact, IPS, CSC for FEP, as well as high fidelity RAP beginning in July 1st of 2026. Going into this, a lot has happened up until now. The Centers of Excellence were selected back in November and began contracting with the state and starting in 2025. In March of 2025, counties received and completed a needs and readiness survey that really did implement or help the COEs really support training and technical assistant materials and developed a statewide implementation plan. Upcoming, you'll notice that we are starting the webinars here in August. And beginning with these webinars, counties are going to have an engagement initiation form that they can submit to really initiate the engagement with Centers of Excellence. Once a county has submitted the EIF form, the Centers of Excellence will be reaching out and scheduling consultations, where at that point, training and technical assistance and materials will be available to counties, and a plan on how to help implement EBPs will be established. Next slide. Next slide. As you're well aware, there's a number of bins that have been released. In this slide, you'll see a timeline for when these have been released by DHCS. The initial one back in April of 2025 outlined the coverage, payment, and compliance requirements for counties as they elect to cover ACT, in fact, under Medi-Cal. And then in May of 2025, a policy guide was released that really supported the implementation of EBPs in both BH Connect as well as BHSA. Upcoming guidance will be coming when it comes to BHSA's minimum service capacity requirements and additional guidance on training, technical assistance, fidelity monitoring, and those data collection requirements will be coming as it applies to both Medi-Cal and BHSA. Slide. Accordingly, you'll see here we have our webinars scheduled in July and August. You'll see the upcoming public comment period across August and September when it comes to EBP training and fidelity standards, as well as that minimum service capacity. Those revisions and finalization will occur September to October, and counties and providers could expect the publication of that guidance happening in October and soon thereafter. And just as a reminder, before we pass the baton over to our Centers of Excellence, if you do have a question, please make sure you drop it in the Q&A. I realize that we're squeezing a lot of information into this webinar, so I have no doubts there'll be some follow-up questions. If anything needs to be clarified, or if you have a question about a specific component, please make sure you drop it in the Q&A. We'll make sure it does get addressed after this call. Now that we've walked through that overview, can we go ahead and switch to the next slide? Overview of the COEs. We're gonna hear from Dr. Bromley with the Public Mental Health Partnerships at UCLA. Dr. Bromley.
Thank you, Patrick. Hi, everyone. My name is Beth Bromley. I'm the director of the Public Mental Health Partnership at UCLA. I'm going to provide a quick overview of our Center of Excellence and its training and technical assistance approach for ACT and FACT. Next slide, please. Because you may interact with each of us, I wanted to quickly introduce you to our core leadership team. I'm Beth Bromley. We have Lisa Davis, our Associate Director. Elizabeth Mackey is our Director of Training. Rosalinda Cardenas is our Administrative Director. Joe Mango directs all of our media. And Nancy Archiga is our Associate Administrative Director. We are a team of university-based clinicians and health services researchers who are committed to supporting public service systems. We've been delivering technical assistance, training, and learning communities for Los Angeles County Full Service Partnership and homeless outreach providers since 2018. For more information about our COE, you can visit the COE Resource Hub or the link to our PMHP website, which is pmhp.ucla.edu/ACT. Next slide. As a Center of Excellence, we'll be working directly with county behavioral health agencies and the ACT-FACT teams. Once an engagement initiation form has been submitted by the county, we will coordinate consultations with county leadership to provide information about training and technical assistance resources, to determine county needs and priorities, and then to connect with individual ACT-FACT teams. Our ACT specialists will support teams throughout implementation by providing comprehensive training and technical assistance. Next slide. ACT is a multidisciplinary model that's been used effectively for nearly 5 decades across the US and internationally. The focal population for ACT is adults over 18 years old with severe mental illness, with high service needs and significant functional challenges. FACT teams specialize in serving individuals with severe mental illness and histories of justice involvement. The service delivery model for ACT and FACT includes frequent assertive contact with a dedicated multidisciplinary team, coordinated field-based and person-centered supports across housing and service sectors, and a set of measurable core components of services that can help teams to ensure they're delivering quality care. Next slide. When ACT and FACT are delivered with fidelity to the evidence-based model, there are a number of positive outcomes we expect teams will achieve for the population of focus. Generally, individuals can expect to see improvements in treatment engagement, housing, quality of life, and other outcomes such as symptoms, community integration, and employment and education. Additionally, hospitalization, use of crisis services like emergency rooms, and involvement with the justice system should be reduced. Next slide. PMHP at UCLA will be delivering training and technical assistance free of charge to ACT-FACT teams and county behavioral health leaders as needed. We'll make available foundational and specialized ongoing education on evidence-based practices that are critical to ACT-FACT teams, such as motivational interviewing, person-centered approaches, and trauma-informed strategies. We'll also make available free of charge technical assistance to initiate and improve ACT-FACT implementation. And this will include learning communities that allow providers to share solutions and strategies with their peers in live sessions and in online message boards. We make all of our resources available online, and we use both synchronous delivery, so that means live online trainings delivered over Zoom, and a variety of asynchronous modalities like recorded videos and podcasts that providers can use at any time on their own pace. Resources are available now in the dedicated ACT-FACT Learning Center, which you can find at learn.pmhp.ucla.edu. EBP.org, and we encourage you to create an account there to be aware of new resources as they become available. Next slide. One of our key roles as a Center of Excellence is to assess teams' fidelity to the ACT-FACT model, and we'll use a stepwise approach to support each ACT-FACT team's progress to full fidelity. Some initial steps that each team can expect include completing a baseline assessment, which is a survey of core components of ACT and FACT teams. We call this baseline survey the Core Components Checklist, and we've created a training called Core Components of the ACT and FACT Service Model, Setting the Foundation for Fidelity, that will be available on August 14th as a recorded webinar. It'll be available on our website and also in the Learning Center following next week's Q&A webinar. And down the road, we'll be conducting formal fidelity assessments, which are in-person site visits in which we rate practices and suggest quality improvement approaches based on the tool for measurement of ACT or the Team ACT. We'll also be providing tailored technical assistance delivered virtually by our PMHP specialists when teams encounter implementation challenges. The goal is for ACT and FACT teams to succeed and to thrive in delivering high quality care that achieves improvements for clients. And we truly look forward to working with you. And I want to emphasize that we learn from you. We really appreciate your feedback and your input. They're critical to us creating products that fit your needs. So you should feel free. Please do contact us. We have a dedicated general email address, pmhpcoe@mednet.ucla.edu. You can contact us with any comments or questions at that general email address, pmhpcoe@mednet.ucla.edu. And with that, I'll pass our baton over to Kate with EpiCal to provide more details on coordinated specialty care for first episode psychosis.
Thank you so much, Dr. Bromley. My name's Kate Hardy, and I am the site lead at Stanford University for EpiCal, and we are going to provide today an overview of our Center of Excellence and our training and technical assistance approach for coordinated specialty care for first episode psychosis. Next slide, please. Thank you. So we have a core team across multiple universities for EpiCal, including UC Davis, UC San Francisco, Stanford University, and UC San Diego. And Katie Perry and Valerie Tryon will be the primary points of contact for the EpiCal counties. As a team, we have over 30 years of experience in early psychosis direct service and evaluation. And for more information about our Center of Excellence, please visit the COE Resource Hub or visit our EpiCal website. Next slide, please. Thank you. As a Center of Excellence, we'll be working directly with our county behavioral health agencies and the CSC teams. Once the EIFs have been submitted by the county, we will coordinate consultations with county leadership, provide information about training and technical assistance resources, provide training and technical assistance to county behavioral health agencies, determine county needs and priorities, and then create training for and provide consultation to the behavioral health practitioners. Next slide, please. Thinking about coordinated specialty care research and evidence, CSC itself is a multidisciplinary model that empowers individuals through shared decision-making. Target population for CSC for FEP is primarily young people and adults aged 12 to 40 with an early onset of first episode psychosis. Services target primarily affective or non-affective psychosis, but may also include individuals who are at clinical high risk for psychosis. This is a service delivery model that includes a team-based approach with core services including case management, psychoeducation, health and behavioral health services that may include individual and group therapy, supported employment and education, family education and support, peer support services, and medication management. Next slide, please. At EBPCAL, one of our main goals is to ensure that our work evolves alongside new findings. This is a rapidly evolving field, and it addresses the unique needs of all of the communities that we have across California. We build on the original coordinated specialty care model with the EBPCAL framework that includes some additional components to this model. So an additional build on to the original CSC model include things like peer and family partners as key members of the core team. We focus on care that is both developmentally appropriate and trauma-informed. We support structured weekly team meetings that bring together a connected, multidisciplinary team to coordinate care and share information openly. And we put a strong emphasis on community outreach and participation to make care easier to access for all. Next slide, please. EBPCAL will be offering training and technical assistance free of charge to CSC teams and county behavioral health as needed. These trainings are offered through our learning management system called Cornerstone. Trainings will be structured by clinical role, and EBPCAL will also provide extended experiential trainings to clinic leadership, therapists, and clinicians. Technical assistance includes things like individual county consultations, by role drop-in sessions, for example, peer support, family services, supported education and employment, psychiatric providers, creating engaging groups, among others. We also offer biannual learning collaboratives based on the requests that we receive from the teams, and then ad hoc requests for additional training and technical assistance. Next slide, please. As I mentioned, Cornerstone is our learning management system that is utilized by EBPCAL and supports the delivery, tracking, reporting, and administration of educational courses and trainings. Cornerstone has the following capabilities. It allows individuals to attend live and asynchronous or on-demand trainings. It allows individuals to take trainings specific to their role at any time in the order that they should be taken. And it supports tracking of the progress of individuals through each of the training components. Next slide, please. As a Centre of Excellence, we plan to implement a stepwise approach to ensure and support teams' progress to full fidelity. Some initial steps that each team can expect include a baseline assessment of fidelity, which involves a structured interview in the core components of the CSC model, and then a fidelity assessment, whereby interviews and health record review supports rating of practices, and from this, the suggestion of quality improvement approaches based on what is known as the FEPS, or the First Episode Psychosis Services Fidelity Scale, developed by Don Addington. EBPCAL County Liaisons consult with programs using the CSC Implementation Manual and Workbook, and will cover topics including things like staffing, training on CSC components, billing and documentation, eligibility for the program team and structure, and fidelity. We also have a Beehive application that collects harmonized data that's relevant to CSC care, that supports the tracking of outcomes, and informs the training and technical assistance approach. Next slide, please. Following on from that and providing some more information about Beehive, Beehive is a custom application for data collection at baseline and every 6 months. There's a core assessment battery, or CAB, that includes various validated measures, and program staff have access to data entered into Beehive, which is summarized by program and by each individual service user, thus supporting clinical decision-making as well. On the right is a chart that depicts the EBPCAL battery, domains by service user, primary support person or PSP, and clinic or clinician. Next slide, please. When coordinated specialty care is delivered with fidelity to the model, there are a number of optimal outcomes to highlight for the targeted population. Individuals can experience a reduction in symptoms and improved quality of life, and a reduction in hospitalization. More generally, the model fosters hope and empowers individuals in their recovery journey through shared decision-making. Generally, individuals will stay connected socially and have an overall improvement of well-being. And with that, I will now pass the spotlight over to Sarah Swanson with the IPS Employment Center to explain more about the approach to IPS. Thank you, Sarah.
Thank you, Katie. So I am Sarah Swanson, and I'm the director of the IPS Employment Center. Next slide, please. Our core leadership team includes myself, Crystal McMahon, who you'll meet in a minute. Crystal will be the lead for training and technical assistance in California. Sandy Reese, Ruth Brock, Jenny Kelleher are all national trainers who will participate in training. And we have Kirk Gutierrez and Laurice Corey, who provide administrative support. Robert Drake, who's one of the co-developers of IPS, is a consultant, and we anticipate adding additional staff as needed. I'm currently the point of contact, but if we receive an EIF, you'll be contacted by both Crystal McMahon and myself. Our experience is that the IPS Employment Center was developed by Bob Drake and Debbie Becker, who were the co-developers of this evidence-based practice. And since 2001, we have been facilitating a learning community for IPS. It initially started with 3 states and is currently 27 states and 8 countries outside of the United States. All these community members gather together at different points and work on specific issues through committees to further our learning about IPS and how to help programs implement IPS effectively and how to help them sustain over time. We'll go to the next slide, please. So I've described our leadership, and I can say that we will serve as consultants to county leadership. When we receive an EIF, we'll contact county leadership to have a discussion about their plans for implementing IPS, their ideas for where they would like to implement IPS, and also discuss what their specific needs might be so that we can provide a training and technical assistance plan just for them. And we also will work directly with contracted behavioral health and IPS practitioners who are working together to help people with employment, and that may be within the county or it could be contracted agencies. Next slide, please. IPS has gone through more than 24 randomized controlled trials, so it's a very well researched approach, and we know that it's effective, and it's based on 8 practice principles. Rather than read all the principles to you, I think I'll tell you a short story that illustrates many of the principles, and that might be easier to digest. So a few decades ago, when I was working in a mental health center, I was an employment specialist, and a client named Chris walked up to me one day and said, "Are you the job lady?" And to be honest, my heart just sunk because Chris was well known as somebody who was frequently getting into trouble and in and out of the hospital. He had ongoing psychosis and polysubstance use disorder. And I thought, how am I going to help Chris with a job? But I knew that I needed to practice 0 exclusion criteria, eligibility based on client choice. So I said, yes, I'm the job lady. And I met with Chris a couple times to learn about his past employment and his current goals. And his preference was to find a job within walking distance of his apartment. So in the next few weeks, I spent time visiting different businesses that were close to his apartment, learning about those businesses and getting to know the managers and finding out about different positions and the type of people they'd like to hire. And I eventually worked with a manager at a diner who was interested in meeting Chris, and Chris was interested in the job. So I went with Chris to meet the manager, and although Chris's interviewing skills were not textbook, um, he was able to convey that he was interested in working, and I tried to help fill in some of the gaps. He got hired on a part-time basis, and my initial concern at that point was that the extra income could be an invitation for him to increase his substance use needs, or not needs, his substance use. So I worked out a plan to pick him up from work on every payday. When he got off his work shift, I would just be sitting out front in my car, and I would ask him if he wanted to go shopping because I knew that he was very impulsive about spending money. And so we would go to the Kmart together, and we'd cash his check, go to the Kmart together, spend a lot of his paycheck. And surprisingly, what he wanted to buy were things for his daughter. Dresses and school supplies was really a side of Chris I hadn't known about. That was very admirable. And as we got to know Chris better, both me and the mental health practitioners, all of our attitudes towards Chris changed, and we were hopeful about him and really believing that he could do positive things in his life. And that really changed his relationships with us. We provided job supports for him for as long as he was working. I think he worked there for about a year and a half, and helped him manage his benefits so that he reported his earnings as he should, and that helped him maintain his job. And with that, I'll pass this off to Crystal.
Thank you, Sarah. Hello, my name is Crystal McMahon. I'm the lead implementation specialist for the California IPS COE. I love helping new IPS programs start up and to see the results over time. Today, I was going to talk briefly about IPS training, data, and program evaluations. As those of you out there who have programs are preparing to implement IPS, a few key pieces stand out. If not already in place, ideally your agencies will move towards integrated mental health and IPS, both service delivery and team meetings. Get ready and prepare for your employment teams to provide community-based services. Hire your employment staff, at least 2 staff, 1 IPS employment specialist, and a supervisor who also provides supported employment. Some IPS teams could be much bigger depending on how many clients would benefit from supported employment. The supervisor will have leadership functions such as data tracking, guiding team meetings, and providing field mentoring to the employment specialist. And then agency leadership will ideally take the lead to champion employment services and help guide implementation. And a little bit about our team's training approach. Everybody at the IPS Center for Excellence team loves and believes in the service. We've been direct service providers ourselves and seen firsthand that IPS can provide outstanding employment outcomes and individualized recovery for people that are in the program. When one of our first training meetings, we're going to meet up with the program in person, about a day and a half. We've got some follow-up virtual sessions. We would like to offer participation with your supported employment team meetings and calls with supervisors in both individualized and group context. We have a developed online IPS course, which is 8 units, a self-paced course that includes homework and feedback. These courses are especially designed for employment specialists, supervisors, peers, and DOR counselors. We're also building a set of training modules and videos that will be available online to access anytime. On technical assistance, we'll visit each participating program in person a couple of times, and our trainers will work alongside your IPS program staff to develop the needed skills to approach employers, develop their practice, track and report outcomes, any other needed steps to meet the established fidelity goals. Next slide, please. As the Center of Excellence, we plan to implement a stepwise or incremental approach to ensure and support the team's progress to full fidelity. Some initial steps that each team could expect would be a baseline assessment, and this is going to be a structured interview with the county or agency leaders that's going to result in a brief written summary to assist programs in preparation for implementation. On your full fidelity assessment, that's going to be a day and a half site visit with a planned schedule. These reviews are going to be based on the well-researched and validated IPS fidelity scale. That tool has 25 items to evaluate within the employment program and agency overall. After the program evaluation, the agency will receive a written fidelity report, a follow-up meeting, and assistance writing an action plan to improve fidelity. Next slide, please. The IPS Employment Center tracks outcomes quarterly at the program, state, and national level, and that includes the number of people served, the number of job starts, the total number of people working, people that are in school, and some information about the IPS program. And the California project also is looking to track justice system involvement, housing, and quality of life. This data platform is currently being built, so we anticipate further conversations with you as we develop data agreements that best fit your agency's needs and interests. Our trainers will help IPS supervisors review data, set goals, and work together to coach the team or individual practitioners. Next slide. IPS supported employment has proven employment and education outcomes for people served by mental health, as well as for some people with other conditions or life circumstance. The IPS is very well researched. The employment rates show that 55% of people who receive the service can work, and compared to 24% for more traditional approaches. Participants in IPS service, they've also worked twice as many months, worked more hours, they've had higher earnings. They also experienced recovery in aspects of life that included higher self-esteem, greater satisfaction with finances and leisure. And we just want to, again, recommend for more information on the outcomes, go to the ipsworks.org site to look at the data and the individual success stories. Our team is excited to start working with you, and we look forward to setting those first meetings. With that, I now wanted to pass the spotlight over to Jack Yasko with Clubhouse International to explain more about the approach to Clubhouse services. Sorry if I mispronounced your name.
No, that's fine, Crystal. Hi, everybody. My name is Jack Yasko, and I'm the Chief Operating Officer with Clubhouse International. And we're on the last one, you guys. Thanks for hanging with us through this hour. I'm going to be going over our training and technical assistance approach with this project. But before I go forward with it, I want to share a testimony that I think is probably our major takeaway. And that is that in my work, I have visited over 200 Clubhouse programs. And I almost always hear verbatim from Clubhouse members. These are the people who have a mental illness and come to Clubhouses. And that testimony is my Clubhouse not only changed my life, it saved my life. And we take those words very seriously in our day-to-day work. And I think should serve as a baseline for your consideration in working with our services. Noah, next slide. So our project team is myself, Lee Kellogg, who's on our call today, who's one of our program officers. Amber McKay is our lead employment program officer. I'll be telling you a little bit more about our three-tiered employment program. And Joel Corcoran is our CEO. Also on this call today is Sarah Brown, who can answer any and all questions related to our quality assurance program. We're also going to be working in partnership with the Clubhouse Coalition California. We have about 18 clubhouses existing in California, 5 of which are accredited. We also have authorized training centers. We have 12 globally, but 5 in the U.S. that we anticipate you'll be interested in sending people to training. And our overall role, we serve as sort of the coordinating center. The Clubhouse model has been around for 70 years. Our role is the coordinating center. We have over 380 clubhouses now operating in 32 countries. And we coordinate training, technical assistance, quality assurance. We have a research arm. And so know that if your program, if you're converting to a clubhouse or starting a new one, our team is ready, willing, and available to try to answer any questions that you have. And we don't have We have a level of humility to not be afraid to say, I don't know, if we don't know the answer to your question. But you'll find that our 380 plus clubhouses, while clubhouses often feel like a family to their members, the larger international group of clubhouses is more than willing to share what works in clubhouses, what challenges have been. So you'd be joining a network of like-minded people who are committed to this way of working. For more information about our COE, visit the COE resource hub link to go to our website, which is chock full of information. Next slide. So this is in this org chart. We're going to be working with, similar to the other EBPs, liaison with the counties who complete the EIF forms and provide training and technical assistance, really on a one-to-one basis, because that might vary. Some of you may be thinking, well, we have this program and we want to convert it to a clubhouse, and that will be a little different from those of you who are looking to start a clubhouse from scratch. And so we're specifically prepared to provide that kind of support with you through a variety of resources in determining what your needs are. How can we be the best help to you folks? And we plan on working closely with a coalition of clubhouses who've been there, done that, have their own unique experiences working in the same in California as well, and rely upon these clubhouses, both their members and staff, to talk to you about how to structure a work order day, how to implement an employment program. And we'll be doing that through an array of training and technical assistance. Next slide. So clubhouses, if this is the first time you're hearing about what they are, they're not residential programs. They're places that people come to during the day as kind of like a community resource hub. We offer people living with mental illness opportunities for making friends, employment, housing, education, and help with accessing medical and psychiatric services in a single, caring, and safe environment. We work primarily with adults, although we've been approached more recently about expanding our services to children, providing community-based, non-clinical services and focusing on psychosocial rehabilitation. The way the clubhouse works, in sort of a 1-minute vignette here, is that members are not forced to come to the clubhouse. It's all voluntary. We want people to be at the clubhouse because they want to be there, not because they're being forced to. But they participate in what we call a work order day. And people will volunteer to help make lunch, to help work on the clubhouse newsletter, to help with the garden and growing things in the garden for lunch. It's a variety of different support services to help members improve their confidence in strengthening their talents, skills, and abilities in whatever their individual goals are. We have an employment and education program designed to help members return to the workforce, go back to school to get their high school diploma, or go on to college to get a degree. Over 40% of the average daily attendance in a clubhouse is employed in a paid job in the community. Not a sheltered workshop, but regular jobs paid the same wages as any other person. One of our strong belief systems is that core reintegration, it happens with people working alongside other people in the community. We have an evening, weekend, holiday program, and sort of in a clinical vernacular, that acts like a wraparound service. As all of you know, living with the mental illness incurs so much social isolation, and so many of our folks are stigmatized and ostracized. And when clubhouses are open on Christmas, Thanksgiving, and celebrating the holidays just like anybody else, it reduces those periods where it's exacerbated into emergency room visits or hospitalizations. And so in a clinical vernacular, it's sort of like a wraparound in that mental illness doesn't end Friday at 5 o'clock and start Monday at 9. So when clubhouses are open, usually they're open on one Saturday a month, one evening per month, but also on all the major holidays. We also provide assistance with community supports related to housing, health, wellness initiatives. As many of you know, people with mental illness die 20 years sooner than people without a mental illness. If that was any other disease, that would be front page news headlines. And we, unfortunately, in our work, we don't get that kind of cachet that others do in providing recovery-oriented services. We also provide regular reach-out activity. We visit people in the hospital, visit them at their homes, and really stay in touch with members on a day-to-day basis. Next slide. So here's how we're going to do this stuff. There's a lot of little bullet points here, but we're going to provide direct support to counties and providers with you guys completing those forms. The immersion training is what we call comprehensive clubhouse training, and that's going to be at one of our authorized training centers. 5 of those, as I mentioned, are in the United States. We also will provide a virtual training for new programs that want to start a clubhouse. There's infrastructure questions about how you're going to be operating as a clubhouse. So we provide a virtual training in that regard. We also will provide specialized training in employment services, primarily through AMBER, and we'll provide in-person training sessions as needed. Our resources will be online, self-directed, and facilitated courses and webinars. We also have a bunch of digital resources for you to access, toolkits, fact sheets, and the like. And also the coalition will serve as a direct line of support to your clubhouses. You'll also have access to our clubhouse seminars and conferences and webinars. Next slide. Here's a helicopter view of our quality assurance process. So clubhouses initially will complete what we call a self-study, and it's a document where we ask you questions. Our model has 37 standards, and we ask a lot of questions about, well, how are you doing with those standards? So a clubhouse will complete those. The faculty that conducts our accreditation is a 2-person team. One person is a staff member or director of a clubhouse, and the other person is a person with the lived experience who's a member at a clubhouse. Both have completed the same rigorous faculty training in order to be to conduct accreditations, and they will come to your clubhouse to do a 2 to 3 day site visit. You'll have a preliminary findings meeting, and it is what we call the findings report, and you'll get a written report with an accreditation status. Once all that happens, it doesn't end. Our faculty is available for ongoing consultation, as is we are at Clubhouse International. This bullet point about the employment guidelines is we will provide you with guidelines on what we look for as far as percentages of members that should be in employment. And again, our accreditation process isn't just evaluative. I think is equally or even more valuable is the consultative aspect. It's one thing, clubhouses usually know what they're struggling with, but to be able to give feedback as to, have you tried this? Have you thought of this? Here's a clubhouse who's gone through the exact same thing as you have. Why don't you talk to this clubhouse in this state, and they'll be able to help you with the area that you're struggling with. So there's a very much hands-on consultative aspect to our accreditation process. Next slide. So one of the ways that we provide where we collect data, how we come up with, how we became an evidence-based practice was collecting data from our clubhouses. Our clubhouses complete what we call a CPQ, which is a clubhouse profile questionnaire. It's a lot of demographic data, it's funding data, it's hours of service, it's how many members are involved in different activities, how the clubhouse is governed, and that data helps us with our quality assurance program. It helps us identify training needs. So even though the model's been around 70 years, we're constantly evolving and seeing where there's gaps in services or what are the greatest needs now. And so that data piece of the CPQ is helpful in that regard. And each clubhouse around the globe completes that. Next slide. So the outcomes associated with clubhouses, we have a lot of data and can provide you with research studies to help make the case for clubhouses, because not only are there, even if you're just looking at it from a cost-effective piece of it, we have evidence that being a member in a clubhouse, they're going to have not only a reduction in psychiatric hospitalizations, but the duration of those hospitalizations. There's going to be a reduction in the involvement in the criminal justice system, and there's going to be a reduction in the involvement in emergency room or other costly clinical kinds of services that don't happen as frequently when you're connected up with a support system such as a clubhouse. On the other end of things, more from the philanthropic piece, that all of our staff, 80% of our staff have grown up in clubhouse careers with well over about 150 years of collective experience in this model, is helping people in through the big door of clubhouse, but through a bigger door out in the community, through going to work, going to school, quality of life, making friends, having meaning and purpose in your life, most of us take for granted in our lives. And for the people that we work with, this is a significant difference in improving their quality of life. And with that, I will turn it back over to Patrick to go through the final slides that highlight the next steps and the engagement opportunities with all of the COEs. Patrick?
Thank you, Jack. So now that you've heard from all of our centers of excellence in their approach to training and technical assistance, I do want to pause. I have no doubt you have a lot of questions, perhaps not being communicated yet. I do see that we have about 10 questions that have come through. With 300 folks on the call, I imagine there's plenty of opportunities to add additional questions. Just as a reminder, we will be tracking any questions, even if not answering on this call, and making sure to respond to them as well as bring them to the Q&A session for next week. So if you have a question related to any of the centers of excellence or on the process, please make sure to drop it in the Q&A chat and we can make sure to cover it at the next call. Next slide. So I know many of you are probably wondering, okay, so what's the next step? The engagement initiation form is something we've mentioned across a lot of the different slides and with the COEs. This is really the county's opportunity to let us know that you're interested in the EBP, you're ready to have some of these conversations related to what it takes to implement these. And so there isn't really a set requirement for what needs to happen prior to an EIF. What I would say, and I think this is probably just a larger public service announcement, go ahead and submit the EIF early. You can submit an EIF, and again, I do need to reiterate that this needs to come from the county. So county BH director or a designee from the county will be the one submitting the EIF. But up to 3 months ahead of the initial consultation. So even if you submit, let's say, we can take Act and Fact, for instance. If a county's decided we're ready to go ahead and start conversations with the Center of Excellence for Act and Fact, so with UCLA, they can submit the EIF. It'll come to HMA and we'll alert the COE. They will make sure to reach out via email within 3 business days. At that time, that's when we coordinate what makes the most sense in terms of scheduling a consultation. We'll talk about what goes into a consultation in just a minute, but that's just the foray and the kind of the initiation of the engagement with the Center of Excellence. By no means is that going to be a one-time visit. I think a lot of counties will probably have a number of engagements with the Center of Excellence, even prior to engaging many of the providers and practitioners that are contracted with the county. So just to reiterate, up to 3 months ahead of your desired consultation, but I definitely would recommend counties submitting EIFs early. I will also say you can submit up to all 7 centers of excellence and 8 once high fidelity wrap comes on, all in one EIF form, or you can do it one at a time. So if Act and Fact is your first EBP, then you want to follow up with CSC for FEP next month, you can submit a separate EIF at that time. So again, counties can submit up to as many as they want, depending on when they're ready to engage with the Center of Excellence. Just as another requirement that we just want to make sure we reiterate, all counties are going to have to submit an EIF by March 31st of 2026, specifically for those BHSA EBPs that are included in that guidance. So Act and Fact, IPS, as well as CSC for FEP, all need to be included in an EIF from every county by March 31st, 2026. The reason for that timeline is to ensure that that consultation with the Center of Excellence, and again, that initial consultation is completed by June 30th. It does not mean it's the only consultation. It just means that that at least starts the process and a consultation can be completed by that time. Okay, next slide. Now, in terms of what is included in the county consultations, and especially as a county is trying to determine whether or not they're ready to move forward, these are some of the items that might be included. And so I think it's important just to consider, what are some of the timelines that we have within the county? What are some of the resources that are available that can help us establish or even expand some of the programs? Thinking through referral sources and even what type of training and technical assistance may be needed. But the county is really expected to work with the COE to really establish what's needed. I think there's been some discussion about how will the Center of Excellence really tailor the training and technical assistance. a lot of it will depend on the county consultations. And what I can say is each of them are prepared to make sure that they're adapting and working with the county to really ensure whether it's a rural county or a geographically dispersed or an extremely large county, that there's some adaptive approaches for how the Center of Excellence is really working with them and establishing that evidence-based practice. So you can see lots of opportunities to engage with the COE. And again, not all of this is going to get covered within that first consultation. However, we do encourage counties to go ahead and submit so that they can engage the Center of Excellence sooner rather than later. I imagine schedule flexibility will start to become an issue if everybody submits towards the end of the time frame. Next slide. So at this point, we're going to go through next steps and how else to engage with the Centers of Excellence. We've already talked about the engagement initiation form that will come in from the counties. We've talked about the upcoming consultations between the COEs and counties. And then once that consultation has happened, the engagement with the practitioners and providers will come soon after that, especially as they train or schedule and tailor their training and technical assistance. In terms of next steps, we do have a question and answer session that will be coming up next week, and you already are registered for that. I will mention that part of that will be live. The other part of that will be addressing any questions that have come in as a part of the Q&A session today. Additionally, I believe it was dropped in the chat that you also are welcome to submit an email if you are unable to use the Q&A function. You're welcome to send an email with your questions. We're happy to log those as well. We'll bring written responses and go over the questions that were submitted, and then we'll also raise any live question and answer session components toward the tail end of that. We will have DHCS representatives as well as representatives from the Centers of Excellence and then HMA as well available to answer those questions. So make sure that you have that registration and that on your calendar for next week. The other opportunity that we have, if you go to the next slide, is the monthly office hours. Now, this is something that will happen after our Q&A session. So starting in September, we're going to have a monthly office hours. There's already been some discussion about whether or not this needs to happen more often, and a lot of it will be dependent on the need. So if it's well attended, if there's a need for making the frequency higher, perhaps even bi-weekly, and depending on the types of topics that come through. I will say the type of questions, the input that is coming in from the counties, if there are themes that can be better addressed in the office hours, we'll make sure to bring those up and make sure those topics are posted prior to the monthly office hours for that month. Additionally, these are going to be offered in September, October, and November. If there's continued interest, we're happy to restart back in January. And then again, we'll also be evaluating as to whether or not monthly is enough, as the Centers of Excellence are also establishing some specific office hours, perhaps specific to their EBP. And then finally, and again, final plug for the day before we wrap up, the Centers of Excellence Resource Hub is going to be your one-stop shop for any and all information. Please go ahead and visit that. You'll see probably on a daily basis that the information is getting updated. It'll also be where you can find information about the Centers of Excellence, links to their websites, as well as additional resources and information associated with that. You can also join the newsletter, and this is also important to recognize. We will be having a newsletter that goes out to everybody who signs up. It also is going to have the latest information related to the Centers of Excellence and the evidence-based practices. And finally, there's a email address where you can submit any questions, both for broadly for the project overall, as well as related to the webinar information that was presented today. And with that, I think I just want to say it looks like we're finishing right on time. I do want to thank our presenters for the information they were able to present today. And thank you for your attendance. And we look forward to answering any questions you may have at next week's question and answer session. And thank you again for attending.